Welcome to this Step 2 Clinical Knowledge Review on Hernia Test-Taking Strategies. This video is brought to you by Roadmap to Residency. Today we are going to break down the most common question patterns you will see on your board exam for hernias, including inguinal, femoral, umbilical, and ventral hernias, as well as incarcerated and strangulated hernias. The goal is not to reteach the entire topic, but to help you recognize patterns and apply test-taking strategies. Make sure you have reviewed the surgery and gastrointestinal sections of first aid and your question bank before or alongside this video. Here is what we will cover today. First, we will learn how to recognize the high-yield question stems for all types of hernias that show up on your boards. Second, we will apply specific test-taking strategies for distinguishing direct from indirect inguinal hernias, identifying femoral hernias, and recognizing hernia emergencies. Third, we will master the next best step question format for hernia diagnosis, repair indications, and surgical emergencies. Before you watch this video, I strongly recommend reviewing the surgery and gastrointestinal chapters in first aid, your question bank, and your surgery review resources. This video focuses on how to apply that foundational knowledge strategically on exam day. Our first strategy is the direct versus indirect inguinal hernia split. This is one of the most commonly tested distinctions on the boards. For indirect inguinal hernias, your buzzwords are a young male with a groin bulge that descends into the scrotum. The hernia travels through the internal inguinal ring, which is lateral to the inferior epigastric vessels. It follows the path of testicular descent through the inguinal canal. Indirect hernias are the most common type of hernia in all age groups and in both sexes. For direct inguinal hernias, look for an older male with a bulge that protrudes through the posterior wall of the inguinal canal, medial to the inferior epigastric vessels. The key anatomic landmark is Hesselbach triangle, which is bordered by the inguinal ligament, the inferior epigastric vessels, and the lateral border of the rectus abdominis. Direct hernias rarely descend into the scrotum. The boards absolutely love testing the anatomic relationship to the inferior epigastric vessels, so make sure you have that detail locked in. When you see a question stem describing a hernia and its relationship to those vessels, that is your clue. Strategy 2 is all about recognizing hernia emergencies. This is extremely high yield for the boards. An incarcerated hernia is one that cannot be reduced or pushed back into the abdominal cavity. Your clues on the exam are a firm, tender, irreducible groin or abdominal wall mass. The patient may have nausea, vomiting, abdominal distension, and signs of bowel obstruction. The key distinction is that with incarceration, the hernia contents are trapped, but they still have their blood supply intact. Now, a strangulated hernia is the true surgical emergency. You will see all the signs of incarceration plus fever, severe pain out of proportion, signs of sepsis, or hemodynamic instability. The blood supply to the herniated tissue is compromised, which means ischemia and necrosis are occurring. This requires emergent surgical intervention. A critical test-taking point is that you should never attempt to reduce a suspected strangulated hernia because you risk releasing necrotic tissue and bacteria into the peritoneal cavity. When you see a question with an irreducible hernia plus systemic signs of illness, always pick emergent surgical repair. Now let us talk about recognizing high-yield question stems. For inguinal hernias, the classic stem describes a young male with a groin bulge that gets bigger with coughing, straining, or standing. It may extend into the scrotum. The exam will often give you the relationship to the inferior epigastric vessels to test whether you can differentiate direct from indirect. For femoral hernias, the classic stem is an older female with a mass below the inguinal ligament in the upper medial thigh. This is critical because femoral hernias carry the highest risk of incarceration and strangulation of all hernia types. Whenever you see a woman with a groin mass, femoral hernia should be high on your differential. For umbilical hernias, the stem usually describes a bulge at the umbilicus, commonly in infants or obese adults. Most infant umbilical hernias close spontaneously by age 5, so observation is appropriate unless the defect is very large. Ventral or incisional hernias occur at a prior surgical incision site and are a common complication after abdominal surgery. Here is our first practice question. A 25-year-old man presents with a bulge in his right groin that he first noticed while lifting heavy boxes at work. The bulge increases with straining and reduces when he lies down. On exam, when you place your finger in the inguinal canal and ask the patient to cough, you feel a mass touching your fingertip, lateral to the inferior epigastric vessels. What is the most likely diagnosis? Take a moment to think through this one. Look at the answer choices: direct inguinal hernia, indirect inguinal hernia, femoral hernia, or umbilical hernia. What clues in the stem help you narrow this down? Let us walk through this answer together. Step 1. Spot the pattern. We have a young male with a groin bulge that increases with straining and reduces when lying down. On exam, the mass is felt lateral to the inferior epigastric vessels. This is the classic presentation of an indirect inguinal hernia. Step 2. Apply the rule. The board rule you need to memorize is that lateral to the inferior epigastric vessels means indirect, and medial means direct. Indirect inguinal hernias travel through the internal inguinal ring and can descend into the scrotum. They follow the path of testicular descent. Step 3. Eliminate wrong answers. Choice A, direct inguinal hernia, is wrong because the mass is lateral to the vessels, not medial. Choice C, femoral hernia, is wrong because the mass is in the inguinal canal, not below the inguinal ligament in the femoral canal. Choice D, umbilical hernia, is wrong because the location is the groin, not the umbilicus. The correct answer is B, indirect inguinal hernia. Remember, when the boards give you the relationship to the inferior epigastric vessels, they are handing you the answer. Here is our second practice question. A 65-year-old woman presents with a painful, firm mass in the right groin below the inguinal ligament. She has had nausea and vomiting for the past 12 hours. The mass is tender, non-reducible, and located in the upper medial thigh. She has no prior surgical history. What is the most likely diagnosis? Think about the demographics, the location of the mass, and the fact that it is not reducible. What does each of those clues point you toward? Let us walk through this answer. First, read the question carefully. The question describes an elderly woman with a mass below the inguinal ligament that is non-reducible, with nausea and vomiting. This is a classic femoral hernia presentation with incarceration. The key clues are the demographics, the location, and the irreducibility. Now, why is femoral hernia the answer? Femoral hernias are more common in women than in men, and they carry the highest rate of incarceration and strangulation of all hernia types. The location below the inguinal ligament in the femoral canal is what distinguishes it from inguinal hernias, which are above the ligament. Choice A, direct inguinal hernia, and choice B, indirect inguinal hernia, are both wrong because those present above the inguinal ligament. Choice D, lymphadenopathy, is wrong because it would not cause nausea, vomiting, and obstructive symptoms. The answer is C, incarcerated femoral hernia. This patient needs urgent surgical repair because of the high risk of progression to strangulation. Now let us review hernia repair indications, which are heavily tested on the boards. For elective repair, symptomatic inguinal hernias in adults should be repaired to prevent complications like incarceration and strangulation. The boards may also test that asymptomatic inguinal hernias can be managed with watchful waiting in select patients, meaning not every hernia needs immediate surgery. However, femoral hernias should always be repaired regardless of symptoms because they carry such a high risk of incarceration. For umbilical hernias in children under 5 years old, observation is appropriate because most will close spontaneously. For emergent repair indications, incarcerated hernias that cannot be manually reduced require urgent surgery. All strangulated hernias are surgical emergencies requiring immediate operative intervention. Signs of strangulation include fever, severe pain out of proportion, signs of sepsis, and peritoneal signs. A critical point is to never attempt reduction of a suspected strangulated hernia. The boards love testing when to operate versus when to observe, so make sure you know these indications cold. Here is our third practice question. A 55-year-old man with a known right inguinal hernia presents to the emergency department with severe groin pain, abdominal distension, nausea, and vomiting for the past 6 hours. On exam, the hernia is firm, extremely tender, and cannot be reduced. He is febrile and tachycardic. What is the most appropriate next step in management? Think about the clinical picture here. What do the systemic signs of illness tell you? And what does that mean for your management approach? Let us walk through this answer. Spot the classic pattern first. We have an irreducible hernia with fever, tachycardia, severe pain, and signs of bowel obstruction. This combination screams strangulated hernia. The blood supply to the herniated tissue is compromised, making this a surgical emergency. Now know the key distinction. Choice A, manual reduction at bedside, is contraindicated in a strangulated hernia. If you reduce necrotic bowel back into the abdomen, you risk perforation and sepsis, which can be fatal. Choice C, elective surgical repair within 1 week, is far too late. A strangulated hernia can progress to bowel necrosis and death within hours. Choice D, observation and pain management, would miss a life-threatening surgical emergency. The correct answer is B, emergent surgical repair. The test-taking pearl here is that whenever you see an irreducible hernia combined with systemic signs of illness like fever and tachycardia, the answer is always emergent surgery. Do not be tempted by conservative management options. Here is a critical test-taking pearl on hernia anatomy and red flags. For anatomic landmarks, remember that indirect inguinal hernias go through the internal inguinal ring, lateral to the inferior epigastric vessels. Direct inguinal hernias go through Hesselbach triangle, medial to the inferior epigastric vessels. Femoral hernias go through the femoral canal below the inguinal ligament. The inguinal canal contains the spermatic cord in men and the round ligament in women. The exam tests these anatomic relationships constantly. For red flags, any hernia that is non-reducible requires urgent evaluation. If you see fever, tachycardia, or severe pain with an irreducible hernia, that suggests strangulation and requires emergent surgery. Femoral hernias in women are the most likely to strangulate, and anytime you see bowel obstruction symptoms with a hernia, think incarceration. These details come up again and again on practice questions, so make sure you can recognize these patterns quickly. That wraps up our hernia test-taking strategies video. Before you go, here are your final tips. Review the surgery and gastrointestinal chapters in first aid and your question bank. Focus on hernia anatomy, classification, repair indications, and surgical emergencies. Practice as many hernia questions as you can to build that pattern recognition. The more question stems you see, the faster you will be able to spot the patterns on test day. If you found this video helpful, please like and subscribe to our channel for more board review content. And if you want personalized help with your board prep or residency applications, visit roadmaptoresidency.com to connect with our expert tutors and residency advisors. We are here to help you succeed. Good luck on your exam, and we will see you in the next video.